on postoperative care of Tetralogy of Fallot. And the purpose of this brief talk is how we in India can strive towards a zero early mortality. Surgery for Tetralogy of Fallot comprises a significant proportion of surgeries for congenital heart disease, even in our country. In most pediatric units, it comprises 20 to 25% of all surgeries for congenital heart disease, and in some units, more than a third of all surgeries for heart disease. In the current era, excellent early discharge survivals of 98 to 99% have been documented in most of the industrialized world. This slide shows the age at repair versus the decade of surgery. The vertical axis indicates the mean age at repair, and the horizontal axis indicates the age, era in which the surgery was performed. And it's evident that in the 1930s and 1940s, surgery for Tetralogy of Fallot was performed when patients were over 20 and 25 years of age, and over the last several decades there has been a diminishing mean age of surgery. And in recent times we're all aware that we are moving towards surgery in not only in infancy but even in the early neonatal period. Now we need to look at what are the causes of early postoperative mortality. It's been well documented that early postoperative mortality is really due to a rapidly worsening early onset low cardiac output state, which in the subsequent slides I will allude to as LCOS, and this very quickly becomes refractory to conventional therapy. This LCOS is often compounded by associated junctional ectopic tachycardia or JET, which would give rise to worsening low cardiac output state. All of this would combine to contribute to a negative cascade of events, finally leading to death. In this scenario, mechanical support or ECLS is really not an option. In fact, ECLS for Tetralogy of Fallot has been associated with dismal discharge survival rates of less than 25% in a recent publication by Chaturvedi et al. In Heart 2004. So now let's look at what exactly we mean by restrictive physiology. In an elegant paper in 1995 published in Circulation, Reddington et al. Characterized the right ventricular diastolic performance after complete repair of Tetralogy of Fallot. As we all know, Tetralogy of Fallot is associated with significant right-sided ventricular outflow tract obstruction, right ventricular hypertrophy, which gives rise to diastolic dysfunction or dysfunction of the relaxation of the right ventricle, which in turn adversely impacts stroke volume of the right ventricle and giving rise to right-sided right ventricular dilatation, septal bulge, diminished left ventricular filling, giving rise to a vicious cycle of low cardiac output. So finally, this is how a restrictive physiology contributes to the early mortality of Tetralogy of Fallot by giving rise to refractory right ventricular failure causing low cardiac output state. This algorithm also indicates the importance and the relevance of a decompressive patent foramen ovale created intraoperatively. This slide indicates the transatrial exposure of the right ventricular outflow tract, and it denotes very clearly a very hypertrophied, stiff, fibrotic right ventricle. This slide indicates our protocol for low cardiac output state management without mechanical support. And what it indicates is a highly systematic approach based on diverse strategies, based on conventional modalities and refinement of conventional modalities. So the various modalities used are volume adjustments, appropriate pharmacological support, surgical strategies, and in this case, creation of a right to left shunt or a decompressive PFO to provide a pop-off for the stiff hypertrophied right ventricle so that we avert a refractory low output state in the absence of mechanical support. Now let's look at the other preemptive strategies which can be initiated in the operating room. One of the papers that was published from our unit was the importance of using intraoperative echocardiography to determine the adequacy of repair so that residual defects could be averted. This paper also looked at leaving significant intraoperative right ventricular outflow tract gradients after repair for tetralogy. And this is an illustrative case. In this slide, you can see what we mean by a dynamic right ventricular outflow tract obstruction. And this slide clearly shows that though there is significant right-sided obstruction, it's dynamic, that in other words, it's not fixed. The obstruction relieves itself periodically. To illustrate this, this is a case study of a 1-year, 10-month-old infant who had underwent surgery for Tetralogy of Fallot. He had severe infundibular and valvular stenosis with a hyperplastic pulmonary annulus and main pulmonary artery. He underwent definitive surgery, a VSD closure, infundibular resection, pulmonary valvectomy, and a transannular patch right up to the bifurcation. The intraoperative echocardiogram showed a huge right-sided right ventricular outflow tract gradient of 98 millimeters associated with a degree of pre-pulmonary regurgitation. The decision was taken intraoperatively not to revise the repair, and the child was brought back to the intensive care unit. The postoperative course was smooth and he was discharged within 6 days. And it's interesting to note that the pre-discharge echocardiogram showed a residual an RVOT gradient of only 25 millimeters. So the take-home message is that a dynamic RVOT is better to leave behind than to leave behind too much pulmonary regurgitation, which would contribute to significant postoperative low cardiac output state. The other practice is to minimize cardiopulmonary bypass-related injury to ensure better postoperative hemodynamics and to reduce the incidence of low cardiac output state. The modalities that are practiced are well-described modalities, which include the use of prophylactic intraoperative corticosteroid therapy, as well as ultrafiltration, both conventional, modified, as well as combined. These help in the removal of inflammatory mediators which contribute to low cardiac output state and also go a long way in reducing the extracellular water which gets on board in association with a prolonged cardiopulmonary bypass. We go back to this slide which depicts the restrictive physiology of Tetralogy of Fallot, since this is the basis of the postoperative management in the intensive care and exemplifies all the modalities that would be used to minimize low output state and manage low output state effectively. Effectively, what this paper showed was that all cases of postoperative Tetralogy of Fallot have varying degrees of postoperative right ventricular diastolic dysfunction. And cardiac output in such infants and children is really related to the degree of diastolic antegrade pulmonary blood flow. So the treatment of low cardiac output state in postoperative tetralogy is optimization or increasing antegrade pulmonary blood flow. So effectively, the prevention of low output state or the management of low output stage hinges on strategies to enhance or increase antegrade pulmonary blood flow. And these strategies are ventilatory strategies as well as hemodynamic strategies. This is a slide indicating important cardiopulmonary interactions. I will draw your attention only to the left side of this slide. And what this shows is the effect of negative pressure ventilation on right-sided filling or right-sided preload. In the normal heart, With negative pressure ventilation, right-sided filling is increased. In the diseased heart, especially in Tetralogy of Fallot, negative pressure ventilation further augments right-sided filling. What are the implications of this observation of cardiopulmonary interactions? In a very elegant study by Laura Shekademian et al., published in Intensive Care Medicine 10 years ago, it was clearly shown that cardiac output in postoperative tetralogy of Fallot was most optimal with negative pressure ventilation. On the left hand, on the vertical axis, cardiac output is delineated. These are infants with postoperative tetralogy of Fallot. On conventional IPPV or positive pressure ventilation, and what this shows is, this is the basal cardiac output. 15 minutes of negative pressure ventilation, the cardiac output improves, and with 45 minutes of negative pressure ventilation, the cardiac output further optimizes. So what are the take-home messages and what is the practical relevance of this data? So effectively, Shekademian's work indicates that negative ventilation is ideal for children with postoperative tetralogy of Fallot, but in reality this is cumbersome and technically not very feasible for routine use. But what this paper does indicate and does reiterate is that there are significant deleterious effects of prolonged positive pressure ventilation in children who undergo repair of tetralogy of Fallot, and underscores the importance of establishing spontaneous respiration as quickly as possible so that cardiac output can be optimized. So to sum up, what are the postoperative ventilatory strategies in the intensive care? The ventilatory strategies include early extubation so that the antegrade pulmonary diastolic flow can be optimized and cardiac output can be optimized. And in case the children are swollen, edematous, and these babies cannot be extubated quickly, then ventilation with shorter inspiratory times, because shorter inspiratory times have been shown to improve and augment antegrade diastolic pulmonary blood flow, improving cardiac output. To give you an example, this is a baby who underwent a VSD closure, infundibular dissection, and decompressive PFO, a 2-month-old, 3.5 kilo baby. Epicardial echo showed a mild residual dynamic RVOT with a gradient of 60 millimeters, was extubated soon after surgery once the bleeding had settled, had a smooth postoperative course, and was discharged successfully on the 6th postoperative day. With all these measures, how do we diagnose early evolving low cardiac output? Our assessment and monitoring has got better. We use a combination of clinical, hemodynamic, and serial biochemical parameters. Everybody has heart rate and left atrial lines placed in so that LA pressures can be monitored. And on arrival, mixed venous oxygen tension and oxygen saturations are monitored. Anion gap and lactates are also monitored. And these are trended so that if there is an adverse trending, an intervention can be initiated. Epicardial echoes are done routinely, and serial echoes are also done in the event that the course of the baby is not as anticipated. The purpose of these is so that vasoactive therapy and hemodynamic support is rational, timely, and appropriate. So what are our hemodynamic strategies? Because of the stiff right-sided ventricle which was shown earlier, our focus is on gentle, gradual volume augmentation so that the stiff ventricle can be adequately preloaded. Lower blood pressures are accepted, and the goal is to avoid too many inotropes and too many catecholamines, which will worsen the right-sided which will worsen any residual dynamic right-sided outflow obstruction. There is immense focus on prevention and control of tachycardia, which would worsen diastolic dysfunction and an earlier recourse to milrinone. To give you an example, this is a 3-month-old, 5.5-kilo baby who underwent definitive surgery for Tetralogy of Fallot, a pulmonary valvotomy, extensive transannular RVOT repair with a decompressive PFO, came off pump effectively with reasonable CPB and cross-clamp times, had some increase in LA return. The intraoperative echo was appropriate. On 0 post-operative day, the left atrial pressure was increased. He was tachycardic. Mean arterial pressures were elevated. He was cold and clammy. Mixed venous oxygen saturation was appropriate. Lactate was appropriate. There was, however, significant endotracheal bleeding. Nitroglycerin was commenced because of these high pressures. Repeat echo showed right-sided diastolic dysfunction. Milrinone was commenced. Subsequently, the child developed borderline blood pressures with pressures only in the 40s. Ionic calcium was low. Calcium infusion was initiated. We did not add any further adrenaline or any catecholamines or adrenaline. The chest X-ray was slightly wet and hazy. An intraoperative PD, which was initiated, poured huge amounts of exudate. He was finally extubated on early 2nd post-operative day, received dobutamine and nitroglycerin for 5 days, milrinone for 6 days, and was successfully discharged on the 9th post-op day. Sometimes what can happen is even after successful extubation, because of right-sided diastolic dysfunction, there is a tendency for right-sided pleural effusions or bilateral pleural effusions to occur. This is an X-ray of a 10-month-old who was extubated very early, and the X-ray on the 1st post-operative day showed a significant right-sided pleural effusion. The baby had become tachycardic, so an X-ray was ordered. And once the chest drain was put in, 225 ml of serosanguinous fluid was obtained, and thereafter the post-operative course was moved. And this is the baby prior to discharge on the 5th post-op day. The next issue is that of junctional ectopic tachycardia. It's a very difficult arrhythmia to treat, so it's best prevented. The methods which are used to prevent junctional ectopic tachycardia it's a potentially dangerous arrhythmia and tends to occur in the first 48 hours after surgery. It's very poorly tolerated, and it can give rise to a vicious cycle leading to severe refractory low cardiac output state. There's a greater predilection for jet in younger infants and those who have hypomagnesemia. So the method of prevention to try and minimize jet is to have a routine practice of checking magnesium levels, and there is published data to indicate that if hypomagnesemia is corrected on time, jet can be minimized. Also, one should have a practice of avoiding needless catecholamines. It's an arrhythmia which is very difficult to treat. It's best prevented. However, if it still does occur, the first thing that one needs to do is to discontinue all adrenergic agents if they're on board, particularly dobutamine, if it's possible. Attempt pacing either using atrial or an atrioventricular sequential modality. If the rate is very fast, amiodarone therapy may be initiated, and if none of these works, for hypothermia could be induced. And these are all well-described modalities to try and manage junctional ectopic tachycardia, but I'd like to reiterate that this is best prevented since it is difficult to manage. Another case study, 6-month-old, had an extensive transannular patch, decompressive PFO, satisfactory intraoperative echoes, was extremely tachycardic, borderline blood pressures, cold and clammy, reduced mixed venous oxygen saturation, mildly elevated lactate, acidotic. Repeat echo showed RV diastolic dysfunction. We commenced milrinone. We adjusted the ventilation, cut short the inspiratory time, could be weaned and extubated rapidly. Now, this is our current practice. In the very early years, what we would have done is the previous response about 10 years ago with such borderline blood pressures would have been to initiate adrenaline. And this would give rise to tachycardia, sometimes jet giving rise to a domino effect on this restrictive physiology, worsening low cardiac output state and death. Sometimes managing these very small infants can be extremely challenging. 2.5-month-old baby, bad anatomy, tetralogy of Fallot with a small left pulmonary artery, presented with a cyanotic spell, stabilized, had definitive surgery, came off pump successfully, increased LA return, satisfactory intraoperative echo but with some pre-pulmonary regurgitation, high tachycardic with high mean arterial pressures, cool toes, SVO2 of 63%, lactic acidosis, significant endotracheal bleeding, repeat echo showed significant right ventricular diastolic dysfunction, milrinone was optimized. Subsequent course was a bit protracted and stormy. The RV diastolic dysfunction continued for a while. We had a period of borderline blood pressures which we managed with calcium infusion, gentle volume augmentation, and corticosteroid therapy. This baby also had a lot of anasarca, which was managed by chest drains, intraoperative peritoneal dialysis catheter, draining about half a liter per day, and continued ventilation. But the point to note is, despite this hypotension, we did not take recourse to any of these catecholaminic agents. What is the rationale for the use of steroids? I draw your attention to a paper published in American Journal of Cardiology which showed the effects of steroids on adrenaline requirement and inotrope score. This is the epinephrine dose on the vertical axis, inotrope score on the vertical axis, before steroids, after steroids. And what this paper clearly showed was a significant reduction in epinephrine requirement and inotrope score after initiation of replacement steroid therapy. What happened to this baby? This baby did need ventilation for a prolonged period of time, for a week, because of anasarca and very wet lungs and persisting endotracheal bleed associated with chest wall edema. Hemodynamic supports were given for 12 days, and finally there was resolution of tachycardia, but even then the baby could be discharged within 2 weeks. Sometimes even after discharge, with free pulmonary regurgitation, one can develop a collection, and it's important to note this. And those children who are present late, who are polycythemic, who have residual free PR, even though they've been successfully discharged, and this was the pre-discharge X-ray, we keep a close watch, and 7 days later, the child was comfortable, had slightly reduced air entry, and this was the chest X-ray which needed a chest drain. And this is the child just before he went home to his village, being held by his elder sister. Now, in India, Tetralogy of Fallot, surgery for tetralogy not only involves infants, but also adolescents, older children who present late, who are polycythemic, who are hypercyanotic, and who also have varying degrees of consumptive coagulopathy. What are their problems? Their problems are due to chronic hypoxemia and the secondary response to chronic hypoxemia, varying degrees of DIC. The chronic hypoxemia often leads to malnutrition, renal dysfunction. There are occult cerebral infarcts, bleeds, or abscesses. Invariably, there are compensatory collateral formation, and in some instances, associated left ventricular dysfunction because of chronic hypoxemia. So their preoperative evaluation really involves a CT scan for occult infarcts, bleeds, and abscesses, an assessment and evaluation of malnutrition, an evaluation of renal function and other end organ function, a preoperative hematology and coagulation profile. Phlebotomy with fresh flows in plasma has been shown to be beneficial in severe polycythemia, especially if the hemoglobin is more than 20 grams per DL. And it's important to arrange blood products, platelets, and fresh frozen plasma for intraoperative and postoperative administration. If that doesn't occur, despite a very good definitive repair, one can have an unfortunate event like this, where this child had a postoperative bleed and succumbed to his bleed. In late presentation, it's also very important to have an assiduous search for collaterals, either by a CT angio or a catheter study. And this is the reason why collateral should be embolized. This is an unembolized collateral, and in the immediate postoperative period, there was significant pulmonary bleed in the area of the collateral. So to sum up, in the polycythemic tetralogy of Fallot, they too have a restrictive physiology, and one needs to pay assiduous attention to the various hematological parameters to avert vital organ bleeds like an intracranial bleed. With all these modalities, our 30-day mortality over the last 15 years has significantly improved. This was the mortality between 1995 to 1999, 3.5%. And from 2001 to 2009, the mortality has been less than 1%. So to conclude, the approach to low cardiac output state should be preemptive, should be aggressive, multimodal, simple, well-described strategies. We need to minimize low cardiac output state by intraoperative measures, surgical strategies with a decompressive PFO, leave behind a residual dynamic RVOT. In all infants, intraoperative peritoneal dialysis catheter should be sited to relieve the ascites so that early extubation can be facilitated. It's important to recognize early evolving low cardiac output state as well, and use all these ventilatory and hemodynamic strategies which were described to optimize antegrade pulmonary diastolic blood flow. Thank you. Hello? Which inotrope should we use? Well, we routinely use dobutamine while separating from cardiopulmonary bypass, and the reason for that is cost issues. If there is significant right ventricular outflow tract gradient, then we use only a low dose of dobutamine. If the residual gradient is very high, then we use nothing. Otherwise, our drug of choice is milrinone, where there are no cost constraints for its lusitropic effect. What should be the ventilatory? The inspiratory time that's optimal that we use and what is recommended is between 0.4 to 0.5 seconds. I can't read the other question. What should be the ventilatory support? Okay, what should be the ventilatory strategy for low cardiac output? The ventilatory strategy for low cardiac output is to try and extubate as quickly as possible. Shekerdinian's paper has clearly illustrated that there is a great advantage in having spontaneous respiration, just like in a Fontan physiology. So what one should try and do is try and extubate early. The contraindications to early extubation are if there's significant endotracheal bleed, if the child is draining because of a consumptive coagulopathy or polycythemia, or if there is a huge amount of anasarca with chest wall edema. The inspiratory time I've already answered. Should a PFO be left in all cases? In infants, certainly especially if the right ventricle is significantly hypertrophied, then there is a great advantage in leaving a decompressive PFO. It certainly reduces the incidence of postoperative low cardiac output. In older children, significant benefit with a decompressive PFO has not been documented. What is the role of fresh frozen plasma in low cardiac output state? Well, we use fresh frozen plasma only if they're deranged coagulation parameters, or if the child is significantly hypovolemic and the hemoglobin is high, then we use fresh frozen plasma. What is the ideal CVP? This will depend upon what the ideal CVP in normal infants is 7 to 8, but if right ventricle is hypertrophied, one would need this higher CVP. The best way to assess an ideal CVP for an individual child is to press the liver and see. And if the hemodynamics get better, that is the CVP. So very often in very restrictive physiology, you may need a CVP of 10 to 12.
You've been done.
So this has to be individualized and decided accordingly. Can crystalloids be used? Yes, we also use crystalloids. If there is no derangement of coagulation, then we use plain normal cells. What dose of calcium infusion should be used? The dose of calcium is really related to the level of ionic calcium, and most blood gas machines would give you the level of ionic calcium. And in some of the very sick tetralogies, the ionic calcium is often very low, especially if the children are growth reduced and malnourished. So we titrate the dose of calcium infusion according to the ionic calcium levels. It could range from 0.5 ml per hour to 2 to 3 ml per hour depending upon the weight of the child and the amount that's required. In the average infant, we start at 0.5 ml per hour. If the calcium level is say 0.6, 0.7 millimoles per liter, then we go up to 1 to 2 depending upon the potassium levels. If the potassium is also low, then care should be given, care should be used while administering calcium infusion because the potassium needs to be corrected. Otherwise, one can have adverse effects due to hypokalemia. What is the degree of core hypothermia in jet? The core cooling up to 35 degrees has been recommended, and that has been shown to break the junctional ectopic tachycardia in some instances. There are many cases where the jet is refractory to induced core hyperthermia as well. Hence, it's very important to try and prevent jet rather than treat it. What is the acceptable RVOTO in the immediate postoperative period? This is a delicate balance and a call which the surgeon has to take in the operating room, and it really depends whether the residual RVOTO is dynamic or fixed. If it is fixed, the surgery has to be revised. If it is predominantly dynamic, as you saw, we've even accepted residual gradients of up to 100 millimeters. But the importance is not the level, the importance is whether it is dynamic or fixed. Thank you very much. Are you limited? Thank you. Thank you. Shall I go offline?